Hello, everyone. So now we're gonna continue another chapter, drug for the skin. It's kind of a big chapter because there's so many drugs that we have to cover here. But because they're topical drugs, basically the adverse effects is gonna be based on the presentation, lotion, creams, gels, and that's basically for the sensitivity. The review that we're gonna be doing regarding adverse effects on these drugs is more on the systemic side. What happens if for some reason the skin absorbs too much of the drug, and now we can see adverse effects in the whole body. So let's get ready to start. Here we go. So drugs for the skin. The most common drug that is used for the skin are the topical glucocorticoids, or topical steroids. The most common one. Why? Because regarding the skin, inflammation of the skin, dermatitis, steroids, like I mentioned in previous chapters, is the best drug out there to take the inflammation away. And obviously, because of the effects that it has on a level, it's gonna affect the ways that the tissue be reacting to it. So again, regarding topical steroids or topical corticoids, the most common symptoms will be is to relieve inflammation, itching, and drying agents. The adverse effects, specifically for the skin, is the apparition of stretch marks. The skin becomes more brittle. So the stretch mark is something very characteristic of someone that is abusing a steroid ointment. Uh, Purpura, we mentioned, it was in a tutoring session where I mentioned that purpura is a specific type of bleeding that is superficial. So it can be seen only on the skin. And purpura is this type of bleeding looks like a bruise. Telangiectasis is the spider web formation that we see regarding the small veins over the skin. Hypertrichosis increase forgot the definition. Sorry, hypertrichosis increase sweat glands, and that's only to fight the drying effect of the corticoid. And if absorbed in great quantities, then we see systemic toxicity. And regarding steroids, we have mentioned the three main ones: increased hyperglycemia, increased hypernatremia, increased sodium, retention of water, and suppressions. So this is a repetition of the previous slides. Regarding the application of glucocorticoids, it's always a thin layer over the skin. Make sure you rub and spread the ointment properly. And don't use any type of plastic to cover it. That will increase the adverse effects of the medication over the skin. Another drug that we use a lot are the keratolytic agents. Keratolytic means the breakdown of keratin. So breakdown of keratin. And keratin is a protein that we're gonna find it on the skin, especially on the skin is thicker, like palms of the hand, sole of the feet. Also, keratin is the one that makes a callus in the hands when hands a lot. So obviously, some people they don't like that overproduction of keratin, so can provide medications to destroy or break down that type of protein, and the that callus or wart can go away. So regarding that, we have salicylic acids. Those are very specific for warts. Also, we have sulfur, and that can be used besides breaking keratin for acne, dandruff, psoriasis, seborrheic dermatitis, and also we have benzoyl peroxide, hydrogen peroxide. It's a variation of hydrogen peroxide. So all these are agents that help with the breakdown of keratin. Now, regarding acne, here we have a whole universe of drugs that can go from just cleaning soap bars. It goes from soap bars all the way to antibiotics, to hormones. So the treatment of acne is can be non-drug therapy, just cleansing soap bars and stuff like that, or we can use chemicals to destroy that acne formation. And again, we'll start with a benzoyl peroxide, very common, is sold on pharmacies, OTC. On severe cases of acne, then the patient will go to a doctor, to a dermatologist, and the dermatologist will provide antibiotics, clindamycin and tetracyclines being the most common ones. And here, sorry, this one is isotretinoin. It's not an antibiotic. I don't know why they put it here. It belongs more with retinoids. It's a variation from vitamin A. So we'll put here tretinoin, isotretinoin. So you can see the relationship just in the name, that they belong to the same group. So isotretinoin, tretinoin, they're variations of vitamin A. So they're not antibiotics. So let's talk about those drugs. Let's see. So regarding antibiotics, the main one that is used is the tetracyclines. So as you can see, they have the cycline ending, tetracycline, doxycycline, minocycline. So this is the most common antibiotic use for acne. We mentioned in a previous chapter, now as a review, tetracycline is not advised on pediatric patients or pregnant patients because tetracyclines, they love calcium. So when this medication is taken, what he mentioned again, the teaching is, because it's very heavy with the stomach, it's going to be a long-term use, it's going to be a few months. They can take it with a snack. And we advise crackers, snacks. Sometimes they think, oh, I can have little pieces of cheese, drink it with milk, but all that has calcium. Tetracycline will attach to the calcium. It will become a big molecule and not get absorbed by the body. So nothing's going to happen. Tetracyclines by itself, they get absorbed, and they're going to look for the calcium in the body, and it will take it from the bones. So that's the reason it's not advised to use on pediatric patients, pregnant patients. If we see toxicity from tetracyclines, then we're going to see staining on the teeth, and that's because they're taking too much calcium from the bone. From the tetracyclines, the most common one, it will be doxycycline and minocycline. Tetracycline is the alternative, and erythromycin. Regarding erythromycin, the mycins, this family is very heavy on the stomach. So it's going to be a lot of abdominal cramps when they take the tablets. Now, this is a very good medication, isotretinoin, and it's a variation or comes from vitamin A. Isotretinoin, you need a prescription to buy it, and is used for that severe acne, aggressive acne. So we call that nodule cystic acne vulgaris. So it's a very, very hard acne that we see on some teenage patients. And the bad side about this medication is teratogenic. So that means that it's going to produce severe malformations on the fetus. So when this patient, especially the female patient, when they go and see the doctor, they need to sign a pledge that they will take 2 types of preventive measurements to avoid pregnancy. That means that they can use a barrier method and a hormonal method to prevent pregnancy. So they have to choose a one from each list. Regarding barriers, is the condom, is the diaphragm. Regarding the hormones, is the birth control pill. So they need to sign that pledge and take those two types of birth control methods, barrier and hormonal. Also, vitamin A increases triglycerides, increases cholesterol indirectly. So they need to do follow-ups like triglycerides. Triglyceride is a building block for cholesterol. So that's the main highlight of isotretinoin, that is very teratogenic. And if the patient is female, then they need to sign that pledge of using two control birth control methods, one a barrier and one a hormonal, in order to prevent pregnancy. Okay, another type of drugs that we have are sunscreens. There's two types of radiation, UV radiations, A and B. Uh, Ultraviolet radiation, type A. This one penetrates the epidermis and dermis. So UVA is more aggressive than ultraviolet radiation type B. So when a patient is very sensitive from the skin, we need to use for sunscreen that specify uh, it blocks UVA radiation. Most of the sunburns on patients are caused by UVB radiation. It only affects the epidermis, and that's when the skin peel off. Regardless of type A and B, the long exposure to this type of radiation eventually is going to promote DNA damage, and that can cause cancer. Usually, it starts with a pre-malignant actinic keratosis. Then eventually, it will evolve to a basal cell carcinoma or a squamous cell carcinoma and malignant, non-malignant melanoma. So patients that abuses of tanning beds, patients that abuses of tanning salons, or they go directly to the beach to tan, uh, they must, it's advised that they must see the dermatologist every so often and make sure that any skin lesion that they see, uh, older wart, has to be inspected by the dermatologist because it can be skin cancer. Now, regarding skin cancer, the only thing that I can tell you is that it doesn't look as aggressive as it sounds. Usually, it will be a mole, not even half an inch big, so it doesn't scare us. It's not draining visually, but underneath the skin, that's when they're doing their damage, they're spreading. So it's advised to all those people that like to have a tan, regardless on how they get it, uh, to go see the dermatologist as soon as they see a skin lesion. Uh, so sunscreens is advised for them to use. We have two type of sunscreens. We have organic screens, which are the chemical screens. This type of sunscreen absorbs the UV radiation and dissipates its heat. Inorganic screen is the physical screen. These ones, they have titanium or zinc oxide and prevents the absorption of UV radiation. Regarding sunscreens, they have a specific measurement, is SPF. This is the units regarding how much protection they can provide. And the protection, the relationship between the SPF, this over here, the relationship between SPS and the protection is not linear. So that means that a sunscreen with a SPS of 30 doesn't mean that protects the double of SPS 15. The only thing that we can tell the patient is, yeah, SPF 30 will protect a little bit more than FPS 15, but the protection is not double just because the number is double. Regarding a sunscreen, adverse effects are minimal. We need to advise the patient that depending on how sensitive they are to sunburns, they need to get a higher SPF sunscreen. And when they go to the beach, to the swimming pool, and they apply that sunscreen, uh, the water, the sweat may wash it off. So every time or every 2 hours, it's advised for them to reapply a layer of sunscreen. Okay, we can jump this. Now, another skin disorder is psoriasis. Psoriasis, and these are red patches with silver scales. It's very common during stress events, and the body reacts, especially the ones where very close to the bone, like the elbows, the knees, the shins, to get swollen, and that constant inflammation, that's constant swelling, eventually uh, will have silver scales, and it's not advised for the patient to take the scale off. They bleed and they're painful. The reason the silver scales they come out is because that area, because of the chronic inflammation, the cells are stimulated to mature faster, but they don't detach from the skin. They don't fall down like a normal skin cell will do. So here we have a lot of options regarding treatment, topical, systemic, phototherapy. So same thing regarding topical drugs, because this is an inflammation process. We can use a glucocorticoid steroid. Also, we can use vitamin D analogs and vitamin A derivatives because they help mature the cells properly and not mutate into the silver scale cell that is characteristic of psoriasis. Also, systemic drugs, if the psoriasis is too severe, now we need to block the inflammation process. And well, we already talked about methotrexate, glucocorticoids, cyclosporin. The new one to the list is citratin, but all of them are immune suppressors. They block the immune system. So the adverse effect of systemic immune suppressors is infections. We talk about it. Regarding glucocorticoids, same thing, because they are able to increase glucose levels. We need to be careful if the patient is diabetic. Also, glucocorticoids, they have a mineral corticoid effect. So that means that they're going to retain sodium, they're going to retain water. So you have to make sure that the patient doesn't have any type of heart failure. Methotrexate, citratin, cyclosporin, for immune suppressors, and the adverse effect here, the immune suppression. So we need to teach the patient that if they have any sign of symptom of infection, to go see the doctor right away. Biological agents. If you notice, most of them they end in MAP, MAP, MAP. So we mentioned that's monoclonal antibodies. So these are immunomodulators. So biological agents is the same as saying immunomodulators. So this is an antibody designed to attack the antibodies, attacking the skin and producing psoriasis. And also regarding procedures for the photochemotherapy, in order to burn those cells and take the inflammation away, or we can use coal tar and ultraviolet B radiation. Another condition of the skin, actinic keratosis. So this is, it looks like acne. This type of acne is a chronic exposure to sunlight, and actinic keratosis is a pre-malignant condition. So that means that it's not treated properly, it's gonna mature or it's gonna move forward, being a skin cancer. So if we have a patient with actinic keratosis, this type of a pre-malignant lesion, again, looks like acne, but melanin. So it's they're dark. It's a dark acne. We can use fluorouracil, fluorouracil. This medication prevents the formation of the malignant cells. That's what it does. Diclofenac sodium. This is an NSAID. Imiquimod. This is also an immunomodulator. And this aminovolanic acid plus blue light, this is phototherapy. So I can use a combination of all this, fluorouracil, to prevent the formation of more premalignant cells. I'm gonna use the diclofenac sodium to stop the inflammation. Imiquimod is an immunolator that's gonna attack the antibodies designed to attack the premalignant cells, and the phototherapy to destroy the DNA of those cells. And that way we don't let it move forward to skin cancer. Another skin condition, eczema or atopic dermatitis, inflammation of the skin, and same thing, because the keyword here is inflammation. One of the best ones is glucocorticoid steroids. And also we can use immunosuppressants. So we have, this is the first group of topical immunosuppressants that we see, that we have seen so far. And as you can see, they end in Cralamus. So we have tacrolimus and picrolimus, immunosuppressants. So that means that they're gonna block all the white blood cells and lymphocytes and inflammation from that area. Regarding questions for the HESI, for the NCLEX, what if this topical immunosuppressant is absorbed by the body? What's gonna happen to the patient? Or it's gonna get immune suppressed. So we need to tell the patient to look for signs and symptoms of infection. And if they have something like that, then it's to go see the doctor for a proper treatment of that infection. Okay, regarding warts, this is venereal warts. So there's warts that are they grow on the genitalia, male and female, and there's different ways of removing those warts, and we have to make sure that we remove them, because they can produce cancer, especially on the female patient. So we can do cryotherapy. That means that we're gonna freeze it, and then those cells are gonna die, and we'll remove them. Electrodissection, we can cut them using electricity. Smells like burned fat when we do this. Smell like chicharrones. We can be more practical and use laser surgery. It's way faster, more precise. Or we can use conventional surgery. Use a scalpel to cut it off. So depending on the conditions of the patient, and also where the patient is going to be treated, those are the different options that they have. Also, we can start using also topical drugs, portofilin, and bichloroacetic acid. Bichloroacetic acid and trichloroacetic acid, BCA and TCA. So these ones are topical drugs that basically they dry the wart off. Because they're very toxic, it's better advised to have the doctor do it in the doctor's office. That way it can control the complications. And the ones at home, topical drugs, well, we have imiquimod, portofillox. Portofillox is a variation of portofilin. The strength is not that high as the one that used in the office. And then we have the Kun Kitakins. So these ones are the ones that you buy OTC without prescription. The only difference between this ones and this one is that they were basically the same, but the strength of the drug is less. Regarding common words, all the words, they are from, they come from the human papilloma virus, HPV. 1, 2, 3, those are the common warts, the one that we see on the skin, on the neck, and the face. Very different from the genital warts that usually is HPV 16. And same thing, we can use physical measures for removing, cryotherapy, electrodissection, laser therapy, regular surgery, or we can use topical drugs to dry them out, and we mentioned them: salicylic acid, podophyllene in the doctor's office, podophylox, imiquimod, trichloroacetic acid. All that can be done at okay. These are miscellaneous drugs, antiperspirants, basically deodorants, medications that block the sweating glands from releasing their product. And what we have here, basically aluminum chlorohydrate, aluminum chloride, and buffer aluminum sulfate. So basically, aluminum, what it does is kind of reduce the flow of those glands by 20 to 50%. That's it. Basically, aluminum interferes with the proper function of the sweat gland, and it's gonna make it more um, less effective to push the sweat out. So it can reduce the amount of perspiration. Aluminum is very common on the deodorants that we get on the stores. Now, the proper term is antiperspirant. Regarding deodorants, carbonylide and triclocarbon, triglycine. This one, they inhibit the bacteria that grows from sweat. So deodorants basically take away the smelly part of sweat. Sweat by itself doesn't have a smell. The problem is, once we sweat, once that gland pushes the sweat out into our skin, then bacteria is able to grow from it, and that's when we have a smelly sweat. Uh, um, so this can stop it. Now, regarding seborrheic dermatitis and dandruff, it has been proved that they're a fungal. It's a yeast, the ones that produce these two conditions, seborrheic dermatitis and dandruff. So we give ketoconazole. This is an antifungal. And you know, this antifungal can be on creams, can be on shampoos, can be on lotions, and so on, to eliminate the yeast and eliminate the seborrheic dermatitis and dandruff. Regarding adverse effects, it's only based on the presentation of the drug. Regarding shampoo, there's not a lot of adverse effects to highlight, but regarding lotions and gels, then we go with, okay, the presentation is a gel, most probably it's gonna sunburns if exposed to the sun. Now, drugs for hair loss, the one that we have to emphasize is finasteride, Pisha. And we have to emphasize this one because the tablet, even though it's in a tablet form, when you grab it, the skin can absorb it very quickly. So finasteride is not allowed to be touched by female nurses that are pregnant. Finasteride favors androgens. Finasteride favors testosterone. So if this female nurse is pregnant and is having a little girl, that a small amount of finasteride that is absorbed can make provide male characteristic to that female fetus. So regarding finasteride, uh, the common advice is make sure you have gloves when you're handling it, and make sure it's in a cup when you provide it to the patient. The other one is minoxidil. That's Reagan, the shampoo. I remember the brand name right now. I don't need it. So topical minoxidil, that's the shampoo that is used for hair loss. Okay, skin infection, impetigo. This is an infection from Staphylococcus aureus or staph aureus. Is very common on kids because they touch their face and they move bacteria around. Um, Staphylococcus aureus usually lives on the skin of nose or the nostrils. So kids from 2 to 5 years of age will pick their nose and then they'll touch their face and will push that bacteria into those areas, and now I'm gonna have a skin infection. Impetigo is we're gonna see redness of the skin, inflammation of the skin with a bolus formation or non-bolus. That means that it's a bolus is like a cyst with water in it, and it's very painful if you see it and you try to pop it. It's very painful when you pop it. So we use antibiotics, penicillin being the most common. Regarding penicillin, the most common questions on the test is, what do you do when the patient is allergic to penicillin? So you change it to one of the mycins. And if the patient is allergic to penicillin, to what else are they going to be allergic? And we mentioned cephalosporins. It's a cross allergic reaction. They're allergic to cephalosporins, they'll be allergic to penicillin. If they're allergic to penicillin, they'll be allergic to cephalosporins. Regarding local anesthetics, we already talked about them. We have benzocaine, lidocaine, 1 eye, 2 eye. So if the patient tells you, I'm allergic to lidocaine, then we need to look for options where there's only 1 eye, benzocaine. And basically that's it for the chapter. And I'll see you on the next one. Thank you very much for your attention.